Hi everyone, welcome to today's video. This is going to be a discussion about case 56, transient loss of vision in the right eye from the Virgilio surgery clerkship book. So without further ado, let's begin with the case study. We have here a 60-year-old male who's coming in with an episode of vision loss in his right eye that occurred 1 week ago when he was watching television, but then it resolved after that. He says it was a curtain or a shade that descended from top to bottom, and he said he didn't have any pain, no headaches, tiredness with his jaw while chewing, or generalized fatigue. And he denied any weakness or numbness related to like a stroke. He has a 30-pack year smoking history. He also has hypertension, hypercholesterolemia. He has no history of coronary artery disease or diabetes. He takes a beta blocker and a statin. His physical exam shows 140/70, blood pressure, normal carotid pulses with a right carotid bruit, and neuro exam is normal. So we've got a pretty broad differential for transient monocular vision loss, although you can tell that there's a lot of keywords here that point to a specific diagnosis. But anyhow, the way that we can differentiate, or like the differential rather, for a person who has like random spontaneous vision loss on one eye that's resolved is can be broken down into circulatory, ocular, and neurological differentials. So for the circulatory, or for like the heart/vascular system, obviously embolus, if there was from the carotid artery, it's there like the arteries that are essentially like in your neck area, right? If they have a embolus, it means that you had a plaque form and then it shooted up into the eye vessels, right? So that's one. And then there's central retinal artery occlusion with a cherry red spot. That's another differential. Severe orthostatic hypotension, giant cell arteritis, because actually that does affect the eye and temporal vessels. So that one is a red flag in terms of like needing to immediately place patients on steroids. So that's why we ask about things like jaw tenderness, headaches, especially in the like lateral sides of the skull, right? The temporal region. And then you have retinal vein occlusion. So instead of the artery, it could be a vein problem. It could be ocular problem, right? Like a retinal detachment, which is where the back wall of the retina basically like rips off of the eye. And so then that will lead to floaters. You have open angle glaucoma, which is increased intraocular pressure. But yeah, anyways, that's not really the presentation here. And then neurologic, oh, sorry, we talked about the ocular differentials, and then there's like pretend this is a brain. And neurologic includes like papilledema, um, optic neuritis, right? Especially association with like multiple sclerosis, and then a retinal migraine or aura are also differentials. But at the end of the day, especially anytime you hear something about like a curtain that comes and goes without any other symptoms like a headache, eye pain, floaters, jaw tiredness, that is very much associated with what's known as amaurosis fugax. Amaurosis fugax is bleeding darkness in Latin and Greek. And so anytime you have that curtain, it's because of that, like likely because of the debris, the embolus that came from the internal carotid artery that is then shooting up to the retina and leads to this temporary symptom. So amaurosis fugax this is how you spell amaurosis fugax. So what is the most high yield and important points to remember about this diagnosis? Firstly, the differentials that I've mentioned. Secondly, the history and physical, right? So what would you expect to see on the history? On a history, you would potentially see a patient having a TIA, or transient ischemic attack, within the 24 hours of having this like symptom of amaurosis fugax, and a stroke potentially even like within or more than 24 hours after this symptom. So because it obviously, like if this is your face, right? And this is the neck area, this is the internal carotid artery, right? And we're saying that there's this clot that went up into the eye. So this clot is still there. It could cause a stroke. It could cause a transient ischemic attack, right? Into the brain, especially. And of course, risk factors that you should ask about is smoking, because smoking has a high likelihood of this type of plaque forming and then ultimately breaking off. Also, you should ask about classic carotid stenosis symptoms. So specifically, things that you can ask about is the amaurosis fugax, of course, which is ipsilateral to the carotid artery that is like blocked. But then also arm and leg weakness and numbness would mean that you've already gotten that clot up to the brain, and then now it's going to cause contralateral symptoms of like what you see in patients who have stroke, right? So asking about the stroke symptoms of arm and leg weakness, especially if they're both on one side, it's contralateral aphasia as well, will oftentimes be associated with a left carotid stroke because of the fact that the Broca's and Wernicke's area on the left side, or sorry, Broca's area is on the left side. And then dizziness, syncope, and headaches are not typical carotid symptoms, just as an FYI. And then stroke, yeah, we already know in terms of epidemiology, it is the fourth leading cause of death in the United States. By the way, I'm specifically talking about the high yield material that is present on page 634 if you have like the most updated Virgilio's textbook. So if you wanted to follow along, that's where I'm at right now. And then the physical exam, besides history, right, we have to ask about things for the physical exam. So for the physical exam, there's something called Hollenhorst plaques, which are emboli to the retina on fundoscopy. And you will actually see like these yellow, like if this is the fundoscopy, and this is like a random artery, you would actually be able to see this like yellowy spot there. I know this is hard to see on with this specific like white background, but there's this little like clot that you would see, and that plaque slash clot is called the Hollenhorst plaque. And carotid bruit, you can also auscultate to listen, right, for this carotid bruit. But just as an FYI, if you hear it, it's very specific for carotid stenosis, potentially leading to amaurosis fugax. If you don't hear it, though, it doesn't necessarily mean that they don't have it, right? Because there's different degrees of stenosis. And now the pathophysiology and pathology is as follows. You have a low shear stress that is promoting atherosclerotic plaque formation is what it says here. So essentially, you have all this debris that builds up, and then eventually a low shear stress, such as if you start to exercise a little bit more, right, then that is going to cause this plaque to embolize. And then that causes the neurological symptoms that we're seeing, especially and only actually in the anterior circulation. So that's actually really high yield. It's important for you to know that it's in the anterior circulation that you're going to see the symptoms of a carotid stenosis plaque that like went up. You should not be seeing any posterior circulation signs because in terms of a carotid disease. Carotid disease. So we're talking here about like the ACA, the anterior coronary artery, and the MCA. And then now and no posterior. The other thing is the carotid stenosis is a marker for coronary artery disease, right? They're all related. If you're having problems of the carotids, you're probably also having problems with the heart, right? So coronary artery, please take a look at the video before in relation to that. And now the most common cause of death in patients with carotid stenosis is actually not a stroke, but it's myocardial infarction. So MIs are very common, and those are the source of mortality. Okay. And then the next section here is about how do we work up this carotid stenosis and ultimately amaurosis fugax. Well, the workup is going to be a carotid duplex to determine the amount of percentage of ICA stenosis. It's actually really important to know what's the percentage because that is going to affect our management. So again, it's called a duplex, which is an ultrasound. And then the confirmatory imaging is also typically recommended, and you will very often in real life see this in especially high academic centers, where they're going to do like a CT angiogram and MR angiogram, right? So CT angio, MRA are used to confirm the diagnosis. Now, management is really where the high yield questions come in because, as I said, it depends on the percent stenosis. And so it's really helpful to be able to differentiate, like, which students know what's going on and like when do we do what, um, using these questions around management. And so the first management step is going to be using potentially something called a carotid endarterectomy. And for carotid endarterectomy, the greatest benefit is going to actually be for patients who are within 70 to 99% ICA stenosis. But then there's less of a benefit for patients who are like it's mediocre for 50 to 69%, and then less of a benefit as well, even for like this is for symptomatic. Symptomatic. It's actually, sorry, let me just like try and make this a little bit more clear. So we use CEA where you go in and you remove the plaque for patients who are especially symptomatic. So that's what SX means. And with 70 to 99% stenosis. So 70 is like a magic number. What about if they are symptomatic, but they just have, like just, as in it's a lot less, 50 to 69% stenosis? What then? Well, it's like moderate benefit. It's still beneficial, obviously, because they're symptomatic, but it's just not as occluded, right, as the first option. And then if they're asymptomatic, so these patients just happen to be lucky, but then what about if it's above 60%? What if they're like 60 to 99% occluded? Some benefit, but not as much. But there's no benefit at all if even if you're symptomatic, even if you're asymptomatic and it's less than 50% stenosis, okay? Then the other option that you can do is something called stenting. Stenting is you put in an actual like balloon basically, or some sort of like metal wire that goes in to through your like vein, so you don't need to make a cut in the neck, and then you stent and you open up like a balloon the area with the embolus. And as you would expect, there is a higher risk of stroke with this specific procedure because you're not getting rid of the plaque, right? It's still there. You're just ballooning it out of the way so that the lumen remains open. And then it's best used though for patients who are symptomatic with IC stenosis, but there is a high heart risk, like a cardiac risk, or they have a hostile neck, like they had radiation there, prior surgery, there's a lesion, right? So there's certain indications for potentially doing a stent instead of a CEA. And then you should also note that this procedure is not recommended for patients with asymptomatic ICA stenosis, right? So not recommended for asymptomatic ICA stenosis. So that's all of the high yield content related to amaurosis fugax and ultimately in ICA stenosis.